Recording of voiceover by Professor Hay of Bipolar Disorder, lecture given in 2015 by Dr. Kim Nguyen. This presentation is based around a case study of Jane, who is a 25-year-old woman who was brought into hospital by her mother. Her mother is concerned that Jane has not been sleeping for the past week and has been spending an excessive amount of money. She has been irritable and argumentative. Jane said her mother is just overreacting. She is having the time of her life as she has a fantastic plan for a new business that would make her very rich. She said she does not sleep so she can work on her business. Who is right, do you think, in this instance? What is the diagnosis and differential diagnosis? And how do you confirm the diagnosis? The next part of the presentation will address these points. The diagnostic criteria, according to DSM-5 for bipolar I disorder, are listed on this slide. I'll let you read through them. As you see, Jane has many of the features for a manic episode. She has a decreased need for sleep. She has an expansive, elevated mood. And she has been doing things which place her at some risk. For example, her business ventures. In addition, the mood disturbance has to be sufficiently severe to cause marked impairment in function, which in this case it has. The symptoms are not due to the direct physiological effects of a substance. In this case, we don't know this. And to be noted that manic-like episodes that are clearly caused by somatic antidepressant treatment should not count towards a diagnosis of bipolar I disorder. There are also criteria for mixed features specifier, which is that someone can have a depressive episode with mixed features or a manic episode with mixed features. The clarification of these is shown on this slide. The differential diagnosis for manic episode is a mood disorder due to a general medical condition. For example, some forms of cardiovascular disorder causing stroke can lead to this picture. A substance-induced mood disorder, many of the currently misused substances in our communities can lead to people with an elevated, irritable mood and associated psychotic features. Bipolar II disorder, where there are no psychotic features or a less severe form of bipolar disorder. And other psychotic disorders such as schizophrenia, schizoaffective disorder or delusional disorder are the main differential diagnoses. How would you manage this patient, Jane? As always, in any psychiatric management, the history and evaluation is very important, and this includes collateral history, particularly in this case from her mother or others, and investigations including brain imaging and biochemistry and hematology, blood screens. In particular, HIV can be a cause of a presentation resembling mania. Establishing safety is very important, and many people may need to come into hospital and or may need to be under the Mental Health Act in order to ensure their safety and protect them from further harm. Often hospital admissions may be very short but followed by intensive community follow-up with further assessments in place by the crisis team. Pharmacotherapy is the mainstay of management for an acute manic episode. This can be either a mood stabilizer or other medication. The most common mood stabilizer used is lithium or sodium valproate. Lithium is an interesting medication. It was discovered or first developed by an Australian psychiatrist, John Cade. It has lower suicide risks than other pharmacotherapy used in bipolar disorder, and it is useful in depressive episodes. However, it has a narrow therapeutic index, and when in toxic levels can cause irreversible damage to kidneys. It also can cause thyroid dysregulation. Thus, the levels of lithium need to be monitored, including renal function and thyroid function every 6 months. Sodium valproate is in some respects easier to use. However, it is not to be used in pregnancy as it is teratogenic. Similarly to lithium, it can also become toxic in higher doses and the levels need to be monitored. It also can cause hepatotoxicity and liver function, and full blood screen looking for thrombocytopenia needs to be done every 3 months. Carbamazepine is another mood stabilizer for which there is somewhat less evidence. It also needs to have its level monitored, including liver function and monitoring for hematological dyscrasias, as well as hyponatremia every 3 months. Then there are a range of second-generation antipsychotics which may be used and are often actually used in acute mania, including olanzapine, quetiapine, aripiprazole, ziprasidone. For these, as always when using antipsychotics, it is important to screen for metabolic syndrome, for diabetes and dyslipidemia every 6 months. Finally, combinations of the second-generation antipsychotics and a mood stabilizer are also often employed. Psychotherapies are used in bipolar disorder. The major ones are cognitive behavior therapy, interpersonal psychological therapy, and importantly, psychoeducation. A common issue in the treatment of bipolar disorder is poor adherence with treatment, and this is addressed with psychological therapies to improve someone's motivation for treatment and also understanding of the role of treatment and its efficacy. This also often includes involving the family in the psychoeducation of treatment of the bipolar disorder. It is important to also monitor the person's physical state and their medications, and we refer you to 2 websites where there is a lot of further information and information for people who have bipolar disorder in regards to its assessment, treatment and ongoing management: the Beyond Blue website and the Black Dog Institute. Further, in bipolar disorder, people suffer from depressive episodes. The treatment of these, however, involves substantial controversy as to when and how to use the antidepressants. It is important to first optimize mood stabilizers, and in particular mood stabilizers that are helpful for people who have depressive episodes are lamotrigine, lithium, olanzapine and quetiapine. Electroconvulsive therapy may also be used in the depressive phase. And finally, antidepressants in conjunction with mood stabilizers can be used, but one must be aware of the potential for inducing mania and rapid cycling of the bipolar episodes with the use of antidepressants. So coming back to the case study, it has been 6 months since her first presentation. Jane is now stable on lithium. She tells you she is planning to get married and is thinking about children, but worried that the medication would affect her pregnancy and her child would also suffer from mental illness. What would you tell her? It is very difficult, as we know that lithium can also cause cardiovascular effects in the unborn child, but compared to other mood stabilizers, it is one with perhaps less teratogenicity than valproate and carbamazepine, which we definitely would not want to use. We may also consider changing her to an atypical antipsychotic to avoid the effects of lithium on the unborn child. It should be possible to reassure her, however, that her child will not necessarily suffer from mental illness. On this next slide is presented the epidemiology of bipolar disorder. In Australia, there is a 1.3% lifetime prevalence for all people and a just under 1% 12 months prevalence, so it is not uncommon. It has equal prevalence in men and women. It has an earlier onset than major depressive disorder, with onset in adolescent years and between the ages of 20 to 50, so very uncommon in older age years. And it is the 6th most disabling condition across the whole of medicine. Also, 50% of all bipolar disorder patients have at least one parent with a mood disorder. And if one parent has a bipolar 1 disorder, the child has a 25% chance of having a mood disorder, and with 2 parents, a 75% chance. So for Jane's children, there is an increased risk, but it is not an absolute risk. Course of bipolar disorder. Sadly, between 10 and 15% of individuals with bipolar disorder complete suicide at some time. Suicidal ideation and attempts are more likely to occur when the individual is in a depressive or mixed state. Bipolar disorder is associated with alcohol and other substance use disorders, particularly with early onset bipolar disorder. And concomitant alcohol and other substance use is associated with an increased number of hospitalizations and a worse course of illness. Bipolar 1 disorder is a recurrent disorder. More than 90% of individuals who have a single manic episode go on to have future episodes. And between 5 and 15% of individuals with bipolar 1 disorder have multiple, that is 4 or more mood disorder episodes that occur within a given year. This is termed rapid cycling. And around a third continue to display mood lability and other residual mood symptoms in between episodes. The criteria for hypomanic episode are listed on this slide, so I'll let you just read through them. These are taken from the DSM-5. On the next slide are further criteria taken from the DSM-5. Criterion C to F. And on this slide I listed the criteria for major depressive episode from the DSM-5. Criterion A is 5 or more of the following symptoms. Furthermore, on this slide, the symptoms do not meet criteria for mixed episode. They cause clinically significant distress or psychosocial impairment, and they're not due to effects of a substance or general medical condition, and are not better accounted for by bereavement. After the loss of a loved one, the symptoms persist for longer than 2 months or are characterized by marked functional impairment, morbid preoccupation with worthlessness, suicidal ideation, psychotic symptoms, or psychomotor retardation would indicate a major depressive episode, however. And again, differential diagnoses for major depressive episode are general medical conditions, substance use disorders, primary major depressive disorder and dysthymic disorder, bipolar 2 disorder, and psychotic disorders such as schizophrenia, schizoaffective disorder, and delusional disorder.